Hello, aspiring RNs, and welcome to our NGN NCLEX RN review. I am your guide to conquering the next generation NCLEX, and today we're diving into the essentials, breaking down complex scenarios, mastering clinical judgment, and nailing those NGN style questions. With fresh insights and practical tips, we'll prepare you to shine on the exam day. So let's get started.
Before moving ahead, I have some exciting news for you. If you are determined to pass the NCLEX within a week or a month, then your best option is to enroll in our complete online NCLEX review crash course right now. This course is a comprehensive all-in-one solution, a guaranteed shortcut, and a proven method to pass. Over the last 5 years, more than 5,000 students have successfully cleared their NCLEX exams using this course with an impressive 99% passing rate. Here's what you'll get: 100-hour animated mini crash course, ideal for those who have limited time and want to pass in just 1 week. 300-hour comprehensive recorded lectures covering 300 high-yield NCLEX topics that the exam loves to test. 5,000 real NCLEX questions, practice with actual past exam questions for better preparation. 15 full-length practice tests, including CAT simulation. Feel confident before your real exam day. Exclusive NCLEX eBook, the ultimate guide you need to pass. 1 year full access. Study anytime, anywhere at your own pace. This is a limited time offer. Enroll now to grab 70% off. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. All right, now let's dive into the topic.
The first test item that we have is a drag and drop close. And the scenario says, a 75-year-old male is admitted to the emergency department with severe lethargy and suspected dehydration. He was discovered disoriented and weak in his apartment by a home health aide who called 911. The patient has lived alone since his spouse passed away 4 years ago. His son reports that over the past week, since his discharge from a hospital stay for a urinary tract infection, the patient has been less responsive, complaining of dizziness, and refusing meals and fluids. Past medical history includes chronic kidney disease, type 2 diabetes mellitus, and a history of stroke. Current medications include furosemide, insulin glargine, aspirin. Vital signs are blood pressure 86/52, heart rate 110 beats per minute, respiratory rate 24, with increased effort, temperature 101.3 degrees Fahrenheit, and oxygen saturation of 87% on room air. So your task is to choose the most likely options for the information missing from the statements below by dragging the correct answers from the list provided into the blanks. So the statements are the following. It says, the nurse decides that the most critical problem for this client is blank related to blank. So the options for the first blank are the following: decreased cardiac output, ineffective breathing pattern, and risk for infection, and fluid volume deficit. For the second blank, the options are hypovolemia, hypoxemia, sepsis, hyperglycemia, acute kidney injury. So what do you think would best fit for the first blank? The answer to that is fluid volume deficit. It's because the blood pressure of this client is low, there's tachycardia, and the poor intake orally, especially for food and fluids, plus the fact that this client is taking diuretics. So this all point to dehydration and fluid volume deficit. And so this or these signs mean that the person probably does not have enough blood volume, which limits how well the oxygen and the nutrients get to the tissues. And if this is not treated quickly, it can become life-threatening. And so this nursing diagnosis really gets to the core of the problem, and it needs to be addressed right away. Now, if you selected decreased cardiac output, that is incorrect, because the main issue is the severe lack of circulating fluid volume. If the fluid volume is corrected, the total cardiac output will somehow be improved, because there's no known history of heart failure here. Now, if you selected an effective breathing pattern, this may be partially correct because the client's breathing is heavily breathing and they also have low oxygen levels, but that's probably because their organs are not getting enough blood and oxygen due to the fluid loss. It's not because there's a primary respiratory problem. And lastly, we have risk for infection. Well, here the patient does have a fever and a recent history of UTI. So an infection could be brewing. But right now, there's no solid proof of sepsis. And since that's only a maybe, we need to focus first on what's clearly happening, which is the severe fluid loss. So your focus should be on an active nursing problem, not a potential problem. Let's move on to our next blank. And so the answer options here, we have hypovolemia, hypoxemia, sepsis, hyperglycemia, acute kidney injury. So the answer here is hypovolemia. And the client's low BP, the tachycardia, refusal of fluids, the use of diuretic, all point to reduce blood volume. And so this is the direct mechanism behind the fluid volume deficit issue, and this must be stabilized and corrected right away. The other options, such as hypoxemia, which is probably reflecting the low O2, there's 87% on room air. So it shows that their body is not getting enough oxygen, but it's not the root of the problem. The main issue is that the person is dehydrated and their blood volume is too low to carry oxygen efficiently into the tissues. So the poor oxygen delivery is actually a secondary issue to the fluid loss. It is not the cause of the overall issue. The next option here is sepsis, which is also incorrect. Yes, there might be a hint that an infection is brewing, such as that the fever is going on. There's that 101.3 degrees Fahrenheit temperature, and also a recent urinary tract infection. But there is not enough proof that the infection is spreading throughout the body. So in other words, it doesn't meet the criteria for systemic infection or sepsis right now. And so the signs that we see, like low blood pressure and tachycardia, are much more clearly explained by the fluid loss than by an overwhelming infection at this point. Hyperglycemia is also incorrect because we cannot even go there. There's no data provided about blood sugar levels. And without any information about glucose, we don't have any reason to think of high blood sugar, which is not really part of the picture here, so disregard that. And lastly, we have acute kidney injury, or AKI. This is also incorrect because the client already has chronic kidney disease and he is dehydrated. You cannot have a patient who has already have a chronic kidney disease and they're going to have acute kidney injury. That is impossible. And so disregard this one as well. And the last statement says, 2 of the nursing actions are blank and blank to prevent further deterioration. So those 2 interventions are the following. The first one is start fluid bolus of normal saline and administer oxygen via nasal cannula to prevent further deterioration. Now, why give fluids right away? So this is to restore the fluid volume the client has lost. And this is very critical because without enough circulating fluid volume, the blood pressure tanks, the tissues do not get enough oxygen, and the organ function will suffer. And if we are going to administer this, the blood volume will improve quickly. You're actually helping the heart pump more effectively and to get the oxygen-rich blood to the body tissues. And at the same time, when you are putting the client on oxygen, even in the low flow O2, this will improve their oxygen delivery to the tissues that are already struggling. So until circulation improves with fluid resuscitation, oxygen support buys time. It will protect vital organs like the brain and the heart. And so these 2 actions go hand in hand and must be done urgently to stabilize this patient. And so if you are selecting deep breathing exercises, well, you might think that this might be helpful for someone short of breath, but this is not appropriate here because the patient is already in respiratory distress. Probably he's exhausted and struggling to breathe. And so if you're asking them to do deep breathing, this can make things worse by increasing their oxygen demand and tiring them out some more. Plus, it doesn't fix the actual problem, which is that the body is not getting enough oxygen due to the low blood volume. Now, what about the application of a cooling blanket? Yes, the client has a fever, but that's not the immediate concern. Right now, the biggest danger is poor perfusion, meaning the blood is not effectively reaching the body organs. And if you selected the cooling blanket, this might reduce the fever, but it does nothing to address the low blood pressure or oxygen delivery that could cause serious organ damage if not fixed fast. Now, what about emergency dialysis? Well, think about that. The client has chronic kidney disease already. So dialysis might eventually be needed, but in this scenario, there's no lab data, there's no symptoms showing that a dialysis is needed right now. There's no information about hyperkalemia. There's no indication that the client has fluid overload. Nothing. So if you're jumping to dialysis in this scenario, you're actually missing the real issue. What we have is fluid volume deficit and low oxygen level. So we got to stabilize those two issues first. Now, lastly, we have offer oral hydration with water. Now, in a normal situation, allowing this person or allowing a person to drink fluids could help, but not here. Our patient has severe lethargy, which makes it so dangerous if you're giving them anything by mouth because they're going to choke, they're going to aspirate. So the safer and the best route would be to administer IV fluids, and this is much more effective in this emergent situation. And so let's go back into the blanks right now. So for blank 1, our goal is to focus on the fluid volume deficit. You gotta address that pressing diagnosis due to the signs of dehydration. And for the second blank, hypovolemia is the direct cause of the fluid volume deficit and the instability in their hemodynamics. And for blank 3 and 4, we're supposed to administer IV fluids and O2 to address the life-threatening conditions of fluid loss and hypoxia. So in this scenario, I want you to prioritize the ABCs. Circulation is the most pressing issue here. The client is showing signs of hypovolemia with a low BP due to the dehydration. They have tachycardia, which is a compensatory mechanism, and the history of refusing fluids and meals. So these compromise the perfusion to the vital organs, and this can lead to shock or organ failure if not corrected immediately. Now also think about the breathing here. The patient is also hypoxic with an O2 SAT of 87%. This also requires immediate intervention. However, the priority remains restoring the circulatory volume through fluid resuscitation, which is going to help improve both perfusion and oxygenation. Let's get into the next item. This is a highlight type of test item. So the case says, a 62-year-old female is admitted to the progressive care unit with a diagnosis of myasthenia gravis crisis. She was brought to the emergency department after her husband noticed worsening muscle weakness, difficulty swallowing, and slurred speech over the past 12 hours. She was diagnosed with myasthenia gravis 5 years ago and has been managed with pyridostigmine and prednisone. She reports missing several doses of pyridostigmine this week due to nausea from a recent respiratory infection. Past medical history includes hysterectomy and osteoporosis. She is a retired teacher and lives with her husband. So your task is to highlight the assessment findings and lab results that need urgent attention from the nurse. So the nurse's progress note says, at 1400 hours, patient arrived in PCU from ED, complaints of severe fatigue and shortness of breath, states, I can barely lift my hands, speech is slurred, oxygen started at 2 liters per minute via nasal cannula per standing order, vital signs blood pressure 148/92, heart rate 98, respirations 26, temperature 99.1, oxygen saturation 90% on 2 liters via nasal cannula. Neurologic exam reveals bilateral ptosis, weak grip strength, 2/5 bilaterally, and diminished gag reflex. IV access established, awaiting neurology consult. At 14:30, patient reports difficulty breathing worsened, respirations at 30 breaths per minute, oxygen saturation 87% on 2 liters per minute via cannula. Notify the respiratory therapist, chest x-ray ordered, pyridostigmine 60 milligrams IV administered per order. Patient's husband reports she had a cold last week with productive cough. At 1500 hours, RT increased oxygen to 4 liters per minute, nasal cannula, respirations 28 breaths per minute, speech increasingly unintelligible, muscle weakness progressing, unable to lift head off pillow. Telemetry shows sinus rhythm, heart rate 102 beats per minute. Now let's look into the lab results. For the ABGs, we have a pH of 7.32, partial pressure CO2 52, partial pressure of oxygen 68, bicarbonate 24, white blood cells we have 16.4, hemoglobin 13.2 grams per deciliter, platelets 220, and sodium 138 milliequivalents per liter, potassium 4.0, chloride 102 rather, BUN 35 milligrams per deciliter, creatinine 1.9 milligrams per deciliter, glucose of 98 milligrams per deciliter. So what do you think are those phrases that you need to highlight here? Again, we're looking for those findings in the lab and nurse's notes that require urgent attention. All right. So one of those is the complaints of severe fatigue. Now, going back into the client's case, we have a patient that has a myasthenia gravis crisis. She has that diagnosis since 5 years ago. And so when they said that they are tired, extremely fatigued, it is likely that their muscles are too weak to function, including the ones that help them breathe or swallow. So we're not just talking about the extremities here, but we're also going to be worried about the respiratory muscles and also the muscles in the GI tract, including the area where the client is supposed to swallow effectively. So this is a huge red flag, and this could mean they're about to go into a full-blown respiratory failure. What else? We got the shortness of breath, obviously, right? Because this points to weak respiratory muscles, which means the lungs cannot expand properly, and without enough air moving in and out, the carbon dioxide builds up and the oxygen will drop, and that can go to a spiral into a respiratory arrest. Now, another thing that you need to highlight here is the states, I can barely lift my arms. So this is that kind of severe muscle weakness, especially in the upper body, and this tells us that their muscles are giving out. And since the same kind of muscles are also the same muscles that will help with their breathing, and this can quickly become life-threatening if not acted on immediately. Another thing that you need to highlight is speech is slurred, and this indicates bulbar muscle weakness. So this is actually affecting the tongue and the throat, which is a very dangerous progression in myasthenic crisis. So this is going to increase their risk of aspiration, and this will worsen their respiratory and swallowing difficulties, and this will require immediate attention to protect the airway. Another thing that you need to highlight is the respirations of 26 breaths per minute. This is tachypnea. It suggests that the respiratory muscles are already starting to get fatigued. This is an early sign of respiratory distress in the myasthenic crisis, and you need to urgently address this. Now, what else do we got? We have an oxygen saturation of 90% on 2 liters. On 2 liters. And this is below the acceptable range, below 95%. So this indicates hypoxemia. So the client here has inadequate oxygenation due to the muscle weakness and requires prompt escalation of oxygen. And also, this client needs ventilatory support. Now, what else do we have? There is that bilateral ptosis. This is classic manifestation of myasthenia gravis. Even though it's not really life-threatening, but this is actually a reflection that the neuromuscular function is worsening, right? It doesn't affect the breathing, but this is a reflection that the muscles, even in the upper body, is actually not functioning this time. This could escalate if not treated quickly. Now, other things that you need to do here is to highlight the weak grip strength. That's 2/5 bilaterally. So this is that level of weakness in the hands. That's a sign of overall muscle strength that is already fading, not just the arms. So this is a subtle sign that the whole body is being affected, including potentially the diaphragm and the chest muscles. Another thing that you need to highlight here is the diminished gag reflex. So in a case of myasthenia crisis, a diminished gag reflex happens because of severe weakness in the bulbar muscles. And this is caused by blocked acetylcholine receptors at the neuromuscular junction. And this is going to impair the pharyngeal muscle's ability to respond, worsened by the muscle fatigue and the systemic effects of the disease. And this also showed that the airway may not be protected. So it increases the risk of aspiration pneumonia or possibly obstruction due to the oral secretions. Another thing that you need to highlight here is patient reports difficulty breathing worsen. So this is a huge red alert. So this is 15 minutes later after the initial assessment. So if a person with myasthenia says that this type of complaint, then this means their breathing muscles are getting weaker fast. And this is not just about discomfort. It could mean that intubation is needed very, very soon. Now, what else do we have? The respiratory rate of 30 breaths per minute. This is also worsening. It usually means the body is trying hard to compensate for the respiratory muscle weakness. It's an early and dangerous sign that breathing support may be needed soon. You got to get the ventilator prescribed. All right, what else? We have an oxygen saturation at 87% on 2 liters via nasal cannula. This reflects severe hypoxemia. Unless corrected quickly, it can lead to organ damage or death. So you got a time to consider more aggressive respiratory support, like maybe a BiPAP or maybe intubation. Another thing that you need to highlight here is the respiratory rate of 28 breaths per minute. So there is persistent tachypnea. Even after the oxygen has been increased, this is suggesting that there is ongoing respiratory distress, and this signals high risk of fatigue and failure. This requires urgent ventilation management. Another thing that you need to highlight is speech increasingly unintelligible. So this also shows bulbar muscle weakness, which actually controls speaking, swallowing, and airway protection. And if you're not going to address this, it can lead to aspiration, and it can eventually lead to blockage of the airways, which are both emergencies. Now, what else we got? We have muscle weakness progressing, unable to lift head of pillow. So this means the neck muscles are too weak to hold the head up. And that's really dangerous because it strongly suggests the respiratory muscles are also weakening, and this patient may need the mechanical ventilator very soon. So let's focus our attention into the lab this time. We have a pH of 7.32, slightly acidic. So this means carbon dioxide is building up, which is a hint of respiratory acidosis, which can worsen quickly. We have a partial pressure of CO2 that is 52. That is too high. It shows that carbon dioxide is not being cleared, maybe due to weak breathing muscles. So this is a huge warning sign. Another is the partial pressure of the oxygen that is very low, 68. That is also showing that the lungs are not working well enough to keep the oxygen level safe. All right, let's move forward to the white blood cell count. That is 16.4. So this is also elevated, suggesting infection, which is a common trigger for the myasthenia crisis. So it's not just a side issue. It could be what set this whole process in motion. So it needs anti-infective ASAP. Now let's move on into the other lab tests. We have the BUN. Look into the 35 milligrams per deciliter. This is elevated. This indicates dehydration or renal stress, which may also exacerbate the myasthenic crisis by impairing the clearance of medications that we are going to give this patient. So this requires fluid management to avoid further deterioration. What else? We got the creatinine of 1.9 milligrams per deciliter. And this also points to the dehydration or the kidney stress. And this makes the crisis worse because it's going to slow down the drug clearance. And this can complicate the treatment. So we're going to have to administer IV fluids here and monitor the renal function. Now, the incorrect answers here include the following. One is the blood pressure. The blood pressure that's actually, where is that? It's high here at 148/92. Okay, why do you think that the blood pressure is not going to call for urgent attention? Well, in this case, we are actually focusing into the airway and the breathing, right? The blood pressure that we have is not in that level that is considered critical. This reading could simply be due to the stress, the pain, or even a chronic hypertension. It's not that dangerously elevated. So it doesn't directly threaten the breathing or the muscle function. So it doesn't need immediate action this time. Now, what else we got? We have a heart rate of 98 beats per minute. It's still within the normal range, even though slightly high. But this could just be a response to anxiety or early respiratory strain, and it's not severely elevated, so it doesn't need urgent attention this time. The same thing with a temperature of 99.1 degrees Fahrenheit. This is within the normal range still, even though it's considered high or maybe low-grade fever. It might hint a possible infection, which can trigger the myasthenic crisis, but it's not concerning enough on its own to take priority. And the heart rate of 102 in the telemetry, okay, above 100 beats per minute. So your client is actually starting to be tachycardic this time. It is regular. It says sinus rhythm. Okay, slightly above normal. So this is going to be a common manifestation, especially when a person is anxious or they have low oxygen level. but again, it's not immediately dangerous. I would be worried if the heart rate is probably in the 120s, 130s, 140s, but at this time, I would not consider this as an urgent assessment finding, all right, or a critical finding. Now let's move to the blood gases. So bicarbonate of 24 is normal. You're not going to worry about that. It's just one piece of puzzle that you don't really have to pay attention to. We have the hemoglobin of 13.2, which is basically within the normal range for this patient. The same thing with the platelets. So here, in this lab, the reference value is 150 to 450. And so this is the thing with the NCLEX questions. You gotta go back into the reference range when it's given in the test scenario. And so if the patient's test result is within that normal range, so that's nothing to worry about. However, if there is no reference range, then you got to stick to the standard nursing lab results. But here we have a value of 150 to 450 as the normal range. So our patient is still within the safe range here. Now, what else? We have the sodium, which is 138. It's still within the normal range. The same thing with the potassium and chloride, and the glucose also. So nothing about those things. All right, so the strategies that you should be using in this test item is to prioritize those life-threatening symptoms. When you scan through the nurse's practice notes, make sure that you capture those very bad assessment findings, those vital signs that are so deviated from the normal ranges. So you got to look for the respiratory issues. The client has shortness of breath, they have difficulty breathing, they have changes in the respiratory rate, and also the saturation. So these findings suggest respiratory muscle weakness, and this is what we need to be worried about in a case of myasthenic crisis. All right. Now, what else do we need to do? You got to focus about the neuromuscular decline, such as weakness in the proximal muscles. The client is unable to lift the arms or the head. There's slurring of speech. There is diminished gag reflex, which all indicate worsening neuromuscular function, which may lead to airway compromise or failure if left untreated. Also, make use of the lab values that we have. Look into the ABGs, such as the pH, the partial pressure of the CO2, and the oxygen. These reveal respiratory acidosis and hypoxemia. So this indicates ventilation failure. So these things should be prioritized because they directly correlate with the risk of respiratory collapse. Also, I need you to distinguish between the chronic versus acute findings. And so you got to look for those signs that reflect an acute decline in their condition, such as worsening on their respiratory rate. So pay attention to the respirations here. Initially, it was, what was that? Respiration. There was nothing in the first assessment, or am I missing that? Okay. At 1430, the respiratory rate is at 30 breaths per minute. That is a huge red flag over there. Oh, so originally it was 26 at 1400, and it went up to 30 15 minutes later. So this is an acute change for this client. And so this is a clear sign of crisis escalation. Now, you also need to rule out infection or dehydration as exacerbating factors. We have an elevated white blood cell count. There is BUN increase, cathecreatin is also increased, which could suggest the infection or dehydration, which could also worsen the myasthenia gravis symptoms. So these findings should be promptly addressed as well, but these are considered secondary to the critical respiratory and the neuromuscular concerns. They also need to be addressed, all right? You also need to utilize the system approach. You got to start by evaluating the findings that threaten first the airway. You got to consider the breathing and finally the circulation. So this is going to help you prioritize what needs immediate intervention. And don't forget about eliminating the distractors. So in the context of myasthenia gravis crisis, you have to avoid being misled by the findings that are more stable and do not indicate immediate life-threatening risks, such as the heart rate that is in sinus rhythm. It doesn't. And the blood pressure that is high, and the glucose level as well. Where's that glucose? 98. So these are likely to require urgent intervention in the context of a crisis. So I hope that you were able to get the majority of the answers here. Moving into the third item. So this is a bow tie, and the scenario says a 78-year-old male with a 12-year history of Parkinson's disease is admitted to the medical intensive care unit from a long-term care facility due to worsening dysphagia and coughing after oral intake. His family reports he has become increasingly rigid with frequent freezing episodes and a decline in mobility over the past month. He was diagnosed with pneumonia 2 weeks ago and completed antibiotics, but his condition has deteriorated. Current medications include levodopa, carbidopa, Sinemet 25 over 100 milligrams every 6 hours, Rasagiline 1 milligram daily, and Ropinirole 2 milligrams TID, though adherence has been inconsistent due to swallowing difficulties. Past medical history includes hypertension, benign prostatic hyperplasia, and recurrent urinary tract infections. Vital signs on admission: blood pressure of 92 over 60, heart rate 112 beats per minute, respirations 28 breaths per minute, temperature 101.8 degrees Fahrenheit, oxygen saturation 88% on room air. Physical exam reveals coarse lung sounds bilaterally, severe bradykinesia, resting tremor, and a weak puff. So your task is to fill in the diagram by choosing from the options provided to identify the problem the patient may be experiencing, 2 contributing factors or risks, and 2 potential complications. Now, for the problem options, the following are aspiration pneumonia, pulmonary edema, acute bronchitis, pneumonia with pleural effusion, partially compensated respiratory alkalosis, and fully compensated metabolic alkalosis. What do you think would be the problem here? Well, the answer to that, before we go do this, let's read the progress notes. There's more additional information. At 8 in the morning, patient admitted to MICU, reports difficulty swallowing solids and liquids, drooling noted, oxygen started 4 liters per minute via nasal cannula, O2 sat improved to 92%, levodopa, carbidopa held due to dysphagia, neurologist consulted for IV alternative, blood pressure dropped to 88 over 54, heart rate 118 beats per minute, IV 0.9% normal saline, initiated at 100 mL per hour, chest x-ray shows right lower lobe consolidation. At 0900, patient remains tachypnic, respiratory rate 30 breaths per minute. Weak cough persists, speech slurred, barely audible, rigidity worsened, unable to assist with repositioning. Temperature spiked to 102.6 degrees Fahrenheit. Sputum culture and arterial blood gas ordered. Family reports he choked on breakfast yesterday at the facility. Moving forward, we have some lab values. pH of 7.3, posture pressure of CO2 50, posture pressure of O2 62, bicarbonate 24, white blood cell count 14.8, hemoglobin 11.8, platelets 180, sodium 132, potassium 4.2, BUN 28, creatinine 1.6. All right, time for you to supplement the blanks, or the boxes, I should say. The answer for the problem is aspiration pneumonia. This is the primary issue because this is supported by the patient's dysphagia, a recent choking incident. Yeah, this one right here. Transfer over here. Drooling noted. There is the nurse withheld the medication because of dysphagia, right? And so all these actually these are hinting that the client has an ongoing issue with the swallowing, and the choking episode that happened are all reflecting that the client has the aspiration pneumonia, and shown in their x-ray, the client developed right lower lobe consolidation. He already has the coarse lung sounds. There's respiratory distress. There's tachypnea, low O2 saturation, and the partial pressure of the oxygen is also low. All right, let me just put it over here. That is very low, guys. And they also have a weak cough, and they have a fever, which further confirm that the aspiration pneumonia is actually active right now. 102.6, right? There's also the drooling, okay? So that would be our definitive problem. Now, moving into the two contributory factors or risk factors, what do you think are those two? So let me have, before we go do that, let me eliminate the other options in the problem. So why not pulmonary edema? Well, if you select pulmonary edema, in the case, there's no evidence of fluid retention. There's no jugular vein distension. There's no peripheral edema. And the client, in this case, has hypotension, 88/54, right? And so the lung sounds also suggest that there is a lung infection going on. It's not about the fluid buildup secondary to the excess fluid volume. It's not pulmonary edema. Now, why not acute bronchitis? Let me just mark them as X. This is also incorrect. Why acute bronchitis is not the answer? We know that there are symptoms that could probably be similar to the acute bronchitis. There's productive cough, there's fever, but the X-ray shows consolidation, and the patient's choking history indicates that pneumonia. So this points more to the aspiration pneumonia, not bronchitis. If you selected pneumonia with pleural effusion, this is also incorrect because the X-ray only shows consolidation. There are no signs of pleural effusion. If you think that this is pleural effusion, you should expect blunting of the costophrenic angles. And so this is not going to be the accurate suspicion of a diagnosis. All right. Now, what about partially compensated respiratory alkalosis? Well, this is an impression that would require a lower PaCO2, right? Take a look into the PaCO2. It's actually 50, right? It's way above the range. So your client is not getting rid of CO2. The patient is actually conserving way too much carbon dioxide. And the pH is also acidotic. So it's not fitting into this partially compensated respiratory acidosis. It isn't. Okay? If you selected fully compensated metabolic acidosis, this would require a high bicarbonate. But look back into the bicarbonate. This only had 24, which is within the normal range. Okay? And it should have a normal pH, but our patient has acidosis in the pH. It doesn't reflect this impression. So we are discarding this as well. Now, finally, we're going to go to the 2 contributory factors and the risk factors. So we have the options: medication non-adherence, recent pneumonia, dehydration, advanced muscle rigidity, poor nutritional status, and urinary retention. So what are these 2? So the answers are the following. First is medication non-adherence. So when a client is inconsistently taking their drugs or medications, particularly the levodopa, carbidopa, this will worsen the symptoms of Parkinson's disease. So they're going to be more rigid, and they will end up with some more bradykinesia. So this leads to further swallowing difficulties and can also increase their risk of aspiration and contribute to the development of the pneumonia. Now, what else? We have recent pneumonia. The patient recently had the pneumonia, which likely weakened the lung function and impaired the clearance of secretions. So this is making him more susceptible to aspiration pneumonia. And the symptoms like fever and elevated white blood cell count further supports that a recent respiratory infection contributed to the current condition. Alrighty. Why not dehydration? It's because let's look into the dehydration here. Yes, there's the BUN elevation of 28. Yeah, that's actually high there. And creatinine of 1.6. Yeah, I understand. But these elevations are considered secondary issues compared to the primary issue that we have, which is the airway and the breathing, the respiratory problem. And so this is not going to be our best pick at the moment. Now, moving into the advanced muscle rigidity. We know that rigidity is a Parkinson's symptom, and its impact is already covered by the medication non-adherence. So it's unnecessary to list separately as a contributory factor. The poor nutritional status is also incorrect. Let me just mark these. The poor nutritional status can lead to nutritional challenges. There is no clear data to indicate that this is a major factor here. So we are also crossing this. And lastly, we have urinary retention. Although the patient has a history of benign prostatic hypertrophy or hyperplasia, there is no evidence linking to urinary retention to the pneumonia or the respiratory issues that we are seeing here. So we're also marking this as a contributory factor. Now let's move on into the potential complications. So we're looking for 2. So the options here are acute respiratory distress syndrome, respiratory failure, septic shock, pneumothorax, pulmonary embolism, and cor pulmonale. So those 2 are the following. There's respiratory failure because the patient's weak cough, there's tachypnea, hypoxia, and hypercapnia all indicate respiratory failure, which is a common and serious complication of aspiration pneumonia, particularly in this patient with Parkinson's disease who is experiencing muscle weakness. The next one is the septic shock. Why? Because the client has fever, they have tachycardia, hypotension, they also have leukocytosis, which suggests an active infection. This strongly suggests that this patient could go into this complication. All right. And the patient's immobility and pneumonia will further increase the likelihood of this severe complication. So, if you selected acute respiratory distress syndrome, that is inaccurate because the patient's hypoxia and consolidation do not meet the criteria for ARDS, which typically involves bilateral infiltrates and rapid onset. So think about that. Another is the pneumothorax, another incorrect option because there are no signs of sudden chest pain, no unequal breath sounds, or air pockets on X-ray, making a pneumothorax unlikely here. Pulmonary embolism is also incorrect. While immobility increases the risk of pulmonary embolism in this patient, there is no sudden onset of dyspnea or other signs like heart strain, and so this makes it less likely than a pneumonia-related complication. And lastly, we have cor pulmonale. Although chronic hypoxia can lead to right-sided heart failure, but there are no acute signs such as right ventricular enlargement that suggest cor pulmonale, and this is not really a major concern at this time. And so that's it for this test item. Let's proceed to the next one. We have a matrix multiple response test item, and the scenario is about a nurse caring for a patient who has undergone a laser peripheral iridotomy, or LPI, for narrow angle closure glaucoma. So your task: for each nursing action listed below, determine whether it is indicated, contraindicated, or irrelevant in the postoperative care of this patient. We have the nursing actions, and so you're going to click on the column, either indicated, contraindicated, or irrelevant. So let's go through the actions here. The first one, it says, administer corticosteroid eye drops as prescribed. What do you think about this? This is indicated because this is a key part of post-op care, and steroid eye drops will help calm the inflammation after a laser treatment. And the LPI uses a focused beam of light to create a very tiny opening in the iris, which can irritate the eye tissues. And so the corticosteroid drops will help reduce the redness, the swelling, discomfort. So this will support faster, smoother healing. Next is encourage the patient to lift heavy objects to test vision. This is contraindicated. Nope. You're not going to allow the patient to lift heavy objects right after eye surgery. This is a very bad idea because lifting will increase the intraocular pressure. That's exactly what we don't want here. And with an elevated IOP, this can stress the healing eye and even reverse the benefits of the LPI. It will trigger complications like bleeding or eye pain. And we want the patient to rest those eyes. We don't want to strain them. Third, action. Monitor for signs of infection at the surgical site. This is indicated. Even though the LPI is a laser procedure and doesn't involve incisions like traditional surgery, but infections can still happen, especially if the patient rubs their eyes or skips their eye drops. So you got to watch out for things like increased redness, swelling, yellow-green discharge, or worsening pain. So early detection equals early treatment. So keep that in mind. All right, next. Teach the patient to avoid rubbing the operated eye. Right? This is indicated. This is a yes, yes, and yes. Because rubbing the eye can be very damaging, especially right after laser surgery. It might seem harmless, but it could increase the pressure, it could introduce the bacteria, or even disrupt the laser-treated area. So you got to educate the patient to resist the urge, even if the eye feels so itchy or irritated. This is a must. Next, instruct the patient to resume contact lens use immediately. Well, this is contraindicated. Definitely not right away, because contact lenses can irritate the healing eye. It will introduce infection, and the eye needs time to calm down after the laser treatment, and most ophthalmologists will advise waiting several days or even weeks before going back to the contact lenses use. All right, number 6, assess for sudden onset of severe eye pain or halos. What do you think about that? This is super important. This is indicated. A severe eye pain, seeing halos around lights, or blurry vision could mean something's going wrong, like a spike in the intraocular pressure or maybe closure of the new opening made by the laser. And so these symptoms are red flags and need to be reported and evaluated ASAP. So you're actually watching for the post-op complications here. Next, we have provide education on the need for follow-up eye exams. Yes, that's very obvious, right? This is a big one. The patient will need ongoing follow-up appointments to make sure the opening stays open and the intraocular pressure remains stable and no new issues develop. And so without follow-up, the patient might not know if the treatment is still working. That's why this is indicated. Next, apply a warm compress to the operated eye to reduce swelling. Big contraindication. This is not a good idea for this case. We know that warm compresses can be soothing in other situations, like maybe a sty or sore muscles, but applying warm compress to an eye that just had laser treatment can actually make things worse. It can increase the blood flow and intraocular pressure. This can potentially aggravate the condition. So what you should expect here instead is cold compresses if approved by the provider, but warm ones, no, you got to skip them for now. Number 9, we have encouraged saline gargles. Do you think that this is indicated, contraindicated, irrelevant? This is irrelevant. This doesn't really fit the situation. The saline gargles are helpful for a sore throat or post tonsillectomy, but they do nothing for the eye. And last, we have instruct the patient to avoid foods high in sodium. This is irrelevant as well. We know that sodium restriction is a big deal in conditions such as heart failure or for those patients that may have fluid overload. But this one doesn't affect the eyes healing after the laser procedure. And the high sodium intake doesn't really spike intraocular pressure in a way that matters here. And so unless the patient has another condition that requires a low sodium diet, then this advice is not related to post-LPI care. So I want you to read carefully the STEM and identify the key details. So you got to focus on the patient's condition, which is a narrow angle closure glaucoma, and the procedure, the LPI. So I want you to note of the context that we are dealing with a patient that is post-op, right? We're actually worried about the post-op care here. So this tells you the priority is about healing, also preventing complications, and also managing the intraocular pressure. So I want you to recognize the test. So classify each nursing action as indicated, contraindicated, or unrelated. And so another aspect here is for you to recall the main purpose of the LPI. Again, this is the creation of that tiny hole into the iris to relieve the pressure, so to improve the aqueous humor flow. And for this patient, our goals should be to reduce the inflammation, prevent infection, also to maintain a stable intraocular pressure, and we need to monitor for the complications such as pain and changes in their vision. And keep in mind about the common interventions here. We are going to expect application or teaching the patient to use the eye drops such as corticosteroids and to avoid activities that will cause increase in the intraocular pressure. So you got to keep this in mind as you evaluate each option. Now, also you have to analyze each nursing action systematically. So you can use a 3-step mental kind of a checklist for each row. And so ask yourself, does this action support the LPI post-op goals? If yes, then that's likely indicated. Or you can maybe ask, could this action harm the patient, or will it worsen the condition? If it is a yes, then likely that is contraindicated. Also, you can ask if this action is unrelated to the eye surgery or glaucoma. If it is a yes, then mark that as irrelevant. So you got to eliminate those obvious mismatches first, then refine your choice. All right, let's move on.
Before moving ahead, I have some exciting news for you. If you are determined to pass the NCLEX within a week or a month, then your best option is to enroll in our complete online NCLEX review crash course right now. This course is a comprehensive all-in-one solution, a guaranteed shortcut, and a proven method to pass. Over the last 5 years, more than 5,000 students have successfully cleared their NCLEX exams using this course with an impressive 99% passing rate. Here's what you'll get: 100-hour animated mini crash course, ideal for those who have limited time and want to pass in just 1 week. 300-hour comprehensive recorded lectures covering 300 high-yield NCLEX topics that the exam loves to test. 5,000 real NCLEX questions, practice with actual past exam questions for better preparation. 15 full-length practice tests, including CAT simulation. Feel confident before your real exam day. Exclusive NCLEX eBook, the ultimate guide you need to pass. 1 year full access. Study anytime, anywhere, at your own pace. This is a limited time offer. Enroll now to grab 70% off. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. All right, now let's dive into the topic.
To our next item, we have a matrix multiple response grouping. I like this one. So the case says a nurse is caring for a 42-year-old male patient in the neuromedical unit who is experiencing status epilepticus. The patient was admitted after presenting with recurrent generalized tonic-clonic seizures. Patient's medical history includes hypertension and a prior stroke 2 years ago. Your task: for each body system listed below, click the nursing interventions that are indicated. So we got the systems: neurological, respiratory, cardiovascular, musculoskeletal. So let's go into each nursing intervention. So under neurological, what do you think about administer IV lorazepam as prescribed? Is this appropriate or is it indicated? Yes, it is, because this is a benzodiazepine. This is commonly used for managing status epilepticus because of its rapid onset of action, and this can also help terminate the seizures by increasing the inhibitory effects of gamma aminobutyric acid, and so this will stop the seizure activity quickly. Now, what else do we have here? You're going to monitor the seizure duration and characteristics to assess the severity of the status epilepticus. And you got to remember that prolonged seizures, especially when the duration is more than 5 minutes, there is an increase in the risk of brain damage, also respiratory compromise and disturbances in their metabolism. So you gotta monitor this patient's duration of seizure to allow for timely interventions and also to help monitor the patient's response to the medication. What else is correct here? Placing a pillow under the patient's head during active seizing. Yes, you got to be quick in doing this one. And this is to allow cushion under the patient's head during a seizure to help protect the patient from head injury due to the violent movement associated with the generalized tonic-clonic seizures. This is a basic safety measure. And so if you selected restrain the patient's arms and legs tightly, that is not supposed to happen, because when you restrain them, this can cause some more injuries. And of course, the client will have those involuntary muscle contractions, and the tight restraints could result into injury to the joints, the muscles, or even the tissues. So what you're supposed to do here is to protect the patient from harm by ensuring the environment is safe and the patient is not at risk of injuring themselves. So do not leave the patient this time. For the respiratory system, the answers are the following. You need to position the patient on their side after seizure activity. This is to help clear their secretions and to prevent aspiration of the saliva or vomitus. And this will also help keep the airway open, and this will reduce the risk of airway obstruction in an unconscious patient. especially after the seizure event is ended. What else? We are going to administer supplemental oxygen as needed, because when seizures, when they are prolonged, this can lead to hypoxia. You got to be worried about blood supply, oxygen supply to the brain. So this will help stabilize the patient's oxygenation. And this will also help prevent neurological damage caused by the hypoxia. What else do we need to do? We are going to suction the airway for excessive oral secretions. So during and after a seizure, the patient will often produce excessive saliva or secretions, which can lead to aspiration or airway obstruction. And when we do this action, this will help clear these secretions, and this will ensure that the patient's airway remains patent. And so if you're going to put or insert an oral airway during an active seizure, this is going to actually cause dental damage and also injury to the oral cavity or tongue. So airway management should be done after the seizure has stopped. And advanced airway management may be necessary if the patient does not resume normal breathing. So keep that in mind. Now, heading to the cardiovascular body system, the answers that you should have are the following. You're going to assess blood pressure at regular intervals after the seizure activity to assess for hypertension or hypotension that may occur due to the seizure. And seizures can cause fluctuations in the blood pressure, and you got to do close monitoring here to identify any cardiovascular instability. Now, if you clicked on massage the chest to stimulate circulation during the seizure, this is contraindicated, also inappropriate, and potentially harmful, because seizure can cause muscle spasms, and trying to massage the chest may interfere with the effective airway management, or it might cause some injury. All right. Now, if you selected administer beta blocker, this is also incorrect, because this intervention is used to treat certain cardiac arrhythmias, but should not be administered during a seizure. Seizures can cause an increase in sympathetic activity, so expect tachycardia, high blood pressure, but beta blockers could exacerbate hypotension and slowing of the heart rate in a potentially already compromised patient. So the focus should be on managing the seizures and stabilizing the cardiovascular system using appropriate and approved measures, not beta blockers. It's never part of that problem. Never part of the interventions, I should say. Now, if you selected apply a cold pack to the chest to reduce tachycardia, this is just invented. This is also not indicated. And the cold therapy could lead to shivering. It would further increase the metabolic demand. So disregard that one. For the musculoskeletal system, we have the options: ensure side rails are padded, move furniture away from the patient during seizure activity, massage the patient's limbs during active seizing to reduce stiffness, and elevate the patient's legs during the seizure to improve circulation. So the answers here are the following: ensuring side rails are padded, never miss that. This is very essential to protect the patients from injuring themselves during a seizure activity. And we know that seizures can lead to uncontrollable movements, so padding the rails is very critical here to reduce incidences of injuries. Another thing that you need to do is move furniture away from the patient during seizure activity to decrease incidences of injury, because the patient may flail uncontrollably, and removing these hazards is also key to ensure the patient's safety. And so massaging the patient's limbs during the active seizure to reduce stiffness is never known to be helpful. During the seizure activity, the muscles are contracted. These are involuntary contractions. And if you are attempting to massage or manipulate the limbs, it could result in injury to the patient. So your focus here should be on ensuring the patient's safety and preventing harm. not massaging or trying to relax the muscles. If you selected elevate the patient's legs during the seizure to improve circulation, is also contraindicated. This could interfere with the patient's position and airway management. So your focus is to protect the patient's head and maintaining a clear airway rather than elevating the legs. And the body should be positioned to ensure safety, but leg elevation during a seizure may not be appropriate or not even helpful. So for this test item, I want you to use the safety first and the ABC framework. And this test item has multiple nursing actions across the different systems. So you got to think about the airway. You got to ask yourself, is the airway clear and protected for this patient? Now, for the breathing, you got to ask, is the patient oxygenating adequately? And for the circulation, ask yourself if there is stable perfusion. And for safety, ask yourself if you are preventing harm during the seizure. And so the strategy, using that ABC framework and safety framework, you're going to apply that to each system. And so for the neurological system, the administration of IV lorazepam will be correct because it will support rapid termination of the seizure. That's part of a safety. And administration of the restraint is usually contraindicated because this increases injury risk. For the respiratory system, your patient should be positioned to the side once the seizure activity has completed, and also suction to protect the airway and prevent aspiration. And we are not supposed to breach the airway safety here. You have to make sure that we are monitoring for their breathing as well. Now, for the cardiovascular system, blood pressure monitoring can happen after the seizure activity. Of course, you're not going to get a reliable blood pressure reading during an active seizure. You can only get that once the patient is post-ictal. All right, so this is to check for any instability in their circulation, and you never massage an extremity during the seizure activity. And for the musculoskeletal system, make sure the rails are padded to prevent injury. That's part of our safety. And do not elevate, do not massage any limbs during a seizure activity because this can worsen possible injuries. All right, let's move on to our last one. So this is actually, this is quite a long test here. This is a matrix multiple choice. So this is a case of a nurse or a unit, nurse educator in the medical surgical unit, teaching newly hired nurses about managing patients with life-threatening arrhythmias. So your task is to match each anticipated nursing action to the type of arrhythmia by clicking on the appropriate columns. So we have on the first column the anticipated nursing actions, and the second column has the third-degree heart block arrhythmia. Atrial fibrillation with the rapid ventricular response. There's ventricular tachycardia with a pulse, pulseless ventricular tachycardia on the fifth column, and ventricular fibrillation on the sixth column. All right, so let's go through each anticipated nursing actions. All right. So it says, administer atropine as prescribed. What do you think about this one? Is this something that would be applicable to all of these, or just one, or maybe two, or three, or four, or none? Well, the answer to this one is for third-degree heart block. We know that atropine is used to increase the heart rate in bradyarrhythmias. And remind yourself about third-degree heart block. There is complete atrioventricular dissociation, and the ventricular rate is dangerously low. And so here, The administration of atropine can enhance the conduction through the AV node and may increase the heart rate temporarily while we await for the placement of maybe a pacemaker. And atropine is not something that you expect to administer in a patient with atrial fibrillation with RVR, because the atropine, as we know, this can increase the heart rate, right? So it's not indicated. So I'm going to put an X over here. This can worsen the condition in AFib with rapid ventricular response, where the goal is to slow the ventricular rate. We don't want atropine here. For the ventricular tachycardia with a pulse, atropine does not address the underlying ventricular arrhythmia here. So this is not going to be effective in treating the VTach with a pulse. The same thing with the ventricular or the pulseless ventricular tachycardia. With the ventricular tachycardia with this is a pulseless, yes. With a pulseless VT, this is a form of a cardiac arrest rhythm, which will require defibrillation, not a vagolytic agent such as atropine. It's not going to address that. Not effective. Now, for ventricular fibrillation, this is a disorganized rhythm which requires immediate defibrillation, and atropine has no role in treating this arrhythmia. So I'm putting an X. Okay, so don't get confused here. The first one is a third-degree heart block, which I put a check mark. So please notice that. The second action, prepare for synchronized cardioversion. What do you think about this? Is this applicable for all? Well, this is applicable only for atrial fibrillation with RVR. And when a patient has a AFib with RVR, they are actually unstable. It means that they have low blood pressure. They could probably go into a chest pain episode. They might end up with altered mental status. So we need to restore the sinus rhythm this time, okay? And so synchronized cardioversion is something that you expect in this problem, because it will deliver a shock at a specific point in the cardiac cycle. We are talking about the R wave. Let me write that down here. Okay, don't get confused. We are talking about synchronized cardioversion. So this is going to reduce the risk of triggering a more dangerous rhythm like ventricular fibrillation. So the timing is very crucial for safety. Now, what about ventricular tachycardia with a pulse? Do you think that synchronized cardioversion is indicated? Yes, it is also indicated here, because in VTach with a pulse, the heart is still pumping blood, but doing so inefficiently. And if the patient starts showing signs of instability like hypotension or loss of consciousness, then synchronized cardioversion is used to correct the rhythm. And the synchronization ensures that the shock is delivered at the right moment to avoid making the rhythm worse. And it is also considered a safer option in patients who are still perfusing but deteriorating. Now, the synchronized cardioversion is incorrect for the third-degree heart block. Big no here. Putting an X mark, because this is a complete block between the atria and the ventricles. Simply means that the electrical signals are not traveling as they should. And since the problem isn't due to a re-entrant or abnormal rhythm that can be reset, synchronized cardioversion will not help in this case. So for this patient with the third-degree heart block, they're going to need pacing, okay? Because it will help restore the coordinated contraction between the atria and the ventricles. Now, for pulseless ventricular tachycardia, the synchronized cardioversion is not indicated as well, because the heart is no longer effectively pumping blood. There is no pulse. And the synchronized cardioversion is not appropriate because there's no meaningful rhythm to synchronize with. And this is a cardiac arrest situation that requires unsynchronized defibrillation. That's why it is incorrect for this one. All right. Along with that, you got to do CPR to try to restart the heart as well. Now, for the ventricular fibrillation, do you think that synchronized cardioversion is indicated? No, because in VFib, this is chaotic. There's no organized electrical activity. There's no identifiable R wave. That means synchronization is not possible or useful here. And so this is a condition that will require a synchronized defibrillation to stop the erratic impulses and to allow the heart's normal rhythm to return. Because this is a life-threatening emergency and time is very critical here. So the only arrhythmias that will be using the synchronized cardioversion are the AFib with RVR and VTAC with a pulse. Let's move forward to our next action. Assess for signs of hemodynamic instability. So we're talking about hypotension, confusion. So this is going to be applicable for the third-degree heart block because the atria and the ventricles beat independently, and this will result to a very slow heart rate. And this can significantly reduce the cardiac output. So you have to assess for any symptoms like low blood pressure, dizziness, fatigue, or syncope to help to determine if the patient is unstable or if they need urgent intervention such as transcutaneous pacing. So the degree of instability will often drive the urgency of the treatment here. Now, this action will also be applicable for AFib with RVR because with AFib and RVR, the ventricles are beating way too fast to fill properly, which can lower the blood pressure, and this will also impair the perfusion. And so monitoring for signs like hypotension, altered mental status, or chest discomfort is key here. And if any of these are actually present, the arrhythmia may be considered unstable, and this will require urgent rate control with medications or synchronized cardioversion as well. Now, let's talk about the ventricular tachycardia with a pulse. Do you think that this action is indicated for this one? Of course, because ventricular tachycardia with a pulse can be stable or unstable depending on the patient's symptoms and perfusion status. And so assessing for signs of instability such as hypotension, the chest pain, or shortness of breath, or maybe altered mental status will help you to determine whether there's immediate need for synchronized cardioversion or if medical therapy is appropriate. So this will also help guide your next management. Now, what about pulseless ventricular tachycardia? Yes, this is also indicated because VTAC, that is pulseless, is a form of cardiac arrest. So the term pulseless itself indicates that there is severe hemodynamic instability. And so assessing and confirming the absence of pulse is critical. It confirms that the patient is in cardiac arrest and you need to do immediate CPR and defibrillation. And so this assessment will help you distinguish it from VTAC with a pulse from VTAC that is pulseless. Now, lastly, we have ventricular fibrillation. This is also indicated. I mean, the action is indicated before this. Let me put the check mark here because there is no effective ventricular contraction that is going on. And as a result of that, there is no pulse. There's no perfusion. So you got to quickly assess for pulselessness. You got to assess for unresponsiveness to confirm the diagnosis and also follow rapid initiation of life-saving measures like CPR and unsynchronized defibrillation. So all check for this row here. Let's move on to our next action. It says administer amiodarone as prescribed. What do you think about that? Well, amiodarone is useful in the treatment of atrial fibrillation with RVR. because the atria are firing chaotically, and this disorganized activity will lead to rapid stimulation of the ventricle. So imagine that. So when you administer the amiodarone, this can help slow down the conduction through the atrioventricular node. This will also reduce how quickly those signals reach the ventricles. Now, when you administer the amiodarone, this will increase the refractory period, which means that it's going to take longer for the cells to be ready to fire again, which will help stabilize the rhythm, and it will reduce the ventricular rate. Now, my NCLEX tip for you here is that there are two main goals in atrial fib treatment. So one is to improve ventricular pumping. That's the first one. The second one is to prevent the occurrence of stroke, like thromboembolic stroke, because we know that with AFib, with RVR, there's going to be stasis of blood in the heart chambers. And this is going to allow formation of blood clots, which can be eventually passed into the cerebral arteries, which will cause a stroke. So think about prevention of stroke and stabilization of the ventricular function. All right. Now, do you think that amiodarone, as prescribed, is also be indicated for the rest of the arrhythmias? Yes, of course. This is something that you can expect as part of treatment for the VTAC with the pulse. So when the patient has this kind of condition, the medication will work by targeting the abnormal areas in the ventricles that are firing too rapidly or are caught in a re-entrant loop. And so when you stabilize the heart muscle and when you interfere with the abnormal circuits, the amiodarone can stop the arrhythmia and it will prevent it from coming back after synchronized cardioversion. So it doesn't really act instantly, but it is effective in controlling the rhythm over time. Now, what about pulseless VTAC? Do you think that this is indicated? Yes, it is. Because we know that pulseless VTAC is a form of cardiac arrest wherein the ventricles are contracting rapidly but not producing any effective blood flow. And so in this case, defibrillation is the first priority. However, here's the big however. If defibrillation alone is not successful in restoring a normal rhythm, then the administration of amiodarone is to be done to help improve the chances of chances of conversion, I should say. So amiodarone per se is going to prolong the action potential and refractory period, which will help suppress the abnormal rhythm, and this encourages the heart to restart a perfusing rhythm. Now, what about ventricular fibrillation? Do you think that the amiodarone will also be effective here? Yes, it is also indicated. We know that ventricular fib is a chaotic rhythm. And just like the pulseless VTAC, the initial step is to do immediate defibrillation. If the rhythm continues despite the shocks or the defibrillation, the amiodarone is also added to the treatment plan. It will help by suppressing to the disorganized activity in the heart muscle. So this gives defibrillation a better chance to work. And this is typically done after the first or the second unsuccessful defibrillation attempt. That is why that's also a check mark for the VFib. However, amiodarone is not indicated for the third-degree heart block. Okay, why is that? It is not appropriate here because the issue in third-degree heart block is complete failure of electrical signals to travel from the atria to the ventricles. And so when you give amiodarone to this person with a third-degree heart block, this could actually make things worse. It will further slow the conduction through the AV node. And since the problem here is not a fast, it's not erratic rhythm, but rather a blocked conduction pathway, the treatment of choice is with the use of a pacemaker, either a transcutaneous pacemaker or maybe a permanent pacemaker to restore the proper coordination between the atria and ventricular contractions. And don't forget about the atropine injection. Yeah. Now let's move forward into the next action. It says prepare for transcutaneous spacing. I think I just said it. So this is going to be indicated for a patient with third-degree heart block, which is complete heart block, because the electrical signals from the atria are completely blocked from reaching the ventricles. This can lead to a dangerously slow ventricular rate. And if the patient becomes symptomatic, maybe they're going to show signs of hypotension, dizziness, or altered mental status, then transcutaneous pacing is the most appropriate emergency treatment here. And it will provide an external electrolyte stimuli to trigger ventricular contractions, and it will temporarily maintain adequate cardiac output until more definitive therapy like a transvenous or maybe a permanent pacemaker can be arranged. And so here, the transcutaneous pacemaker is not indicated for AFib. I'm putting a check, an X mark here, because this is a condition that is a fast heart rate. It's tachyarrhythmic. It is not a slow one. And the problem lies in the rapid and irregular impulses reaching the ventricles, not a lack of conduction. And so remember that pacing is used for bradyarrhythmias. It's not for controlling a high ventricular rate. So the management will typically involve medications like beta blockers or calcium channel blockers like diltiazem to slow the heart rate, and also with the use of the synchronized cardioversion if the patient is unstable. Now, the transcutaneous pacing is also not indicated for ventricular tachycardia with a pulse. I'm just trying to eliminate those heart conditions or arrhythmias that are not indicated for the actions. And so with this VTAC with a pulse, the issue is an organized but dangerously fast rhythm originating in the ventricles. So pacing is not useful here because the heart is already beating rapidly, and the treatment of choice is synchronized cardioversion if the patient is unstable, not a pacemaker. Same thing with the pulseless ventricular tachycardia. I'm putting an X mark here. This is not indicated in this arrhythmia. In this emergency, there's no time to attempt pacing. It would be ineffective. And so what you need here in pulseless VTAC is immediate defibrillation and high quality CPR. The same thing with ventricular fibrillation, right? Next, we have administered diltiazem as prescribed. Do you think that this is going to be effective and all? Well, this is something that is indicated for a patient with atrial with RVR. This is going to help slow down the heart rate. It is going to work by blocking the channel blockers. It will work as a channel blocker, I should say. And it will work particularly on the atrioventricular node, which will reduce the number of electrical signals that reach the ventricles. So this is going to slow the ventricular response, and this will help stabilize the rhythm, especially in a hemodynamically stable patient. And so lowering the heart rate can improve symptoms like palpitations, shortness of breath, and dizziness. And so this is something that is incorrect for a third-degree heart block. Okay, diltiazem is not indicated here because your patient already has a very slow rhythm. You don't want to cause, or you don't want to worsen the client's low heart rate here. All right. So do not administer diltiazem for a patient with a third-degree heart block. And the same thing with a patient with a ventricular tachycardia with a pulse. Remember that with VTAC, with a pulse, the rhythm originates in the ventricles. And because the problem starts in the lower part of the heart, when you slow the conduction through the AV node, which is located higher in the conduction pathway, it doesn't correct the ventricular tachycardia with a pulse. What you have to administer here instead is the diltiazem. Okay, diltiazem is not going to be effective here if you are administering it to a patient with a VTAC with a pulse. Okay. All right. Now, what about the pulseless ventricular tachycardia? Do you think that this is going to be also correct? No. Even though the heart has electrical activity here, it is not pumping the blood effectively. And since this is a life-threatening emergency, the treatment should focus on high-quality CPR and defib. The diltiazem here does not help in restoring the perfusion rhythm in the situation. It has no role in managing VTAC with pulseless VTAC. And the same thing with the VFib as well. So we are going to put X marks here. So let's review real quick. Diltiazem is only indicated for AFib with RVR. Next, we have establish an IV line and administer fluids. What do you think about this? Well, of course, this is going to be applicable for all of these arrhythmias. Check all these boxes. For the third-degree heart block, you got to make sure that the client has IV access to allow quick administration of medications like atropine, and this will also provide a route for fluid resuscitation if hypotension is present. The same thing with AFib with RVR. You need to make sure that you have an IV access to administer a medication IV to control the rapid rhythm and also to prepare the client for cardioversion. The same thing for VTAC with the pulse. The IV fluids can support perfusion, and the IV access will also allow you to deliver those emergency medication to do the conversion, cardioversion, I should say. Now, for the pulseless ventricular tachycardia, you have to make sure that the patient has IV access as well, so you can administer those emergency medication according to the ACLS protocols. And the same thing with VFib. This is going to enable you to deliver possible drugs such as epinephrine or amiodarone during resuscitation if the patient is not improving after high quality CPR or the defibrillation. Let's move into our next action, which is monitor for signs of stroke or embolism. This is something that you are going to apply for a patient with AFib with RVR. We know that with AFib RVR, the atria are not contracting effectively, and so this can cause the blood to pool within the atria, especially in the left atria. So this is going to put the client at risk for clot formation. And when that happens, when it dislodges, it can travel to the bloodstream and block the vessel in the brain. This can lead to ischemic stroke. And that's why it's important to monitor for neurological changes such as confusion, facial droop, speech difficulties, or weakness on one side of the body. And these may be early signs of embolic stroke. So you gotta do that stroke prevention early on. Alrighty, now, why not applicable to third-degree heart block? Well, it's because in third-degree heart block, the electrical signals between the atria and ventricles are completely blocked, but the atria usually still can contract it in an organized way. But unlike AFib, there's no chaotic atrial activity that will cause blood to stagnate or to form clots. And since the risk of atrial thrombus or embolic stroke is not elevated in third-degree heart block rhythm, monitoring for stroke symptoms is not routine here. So we are going to put an X mark this column. Now for ventricular tachycardia with a pulse, what do you think about this? Remember that with VTAC with a pulse, it originates in the ventricle. So it is bypassing the atria entirely in terms of rhythm control. And because the atria are not fibrillating or contributing to the stasis, there is no increased risk of clot formation due to ineffective atrial contraction. So the focus in VTAC with a pulse is more on managing the rhythm and ensuring hemodynamic stability rather than monitoring for embolic complications. So I'm putting an X mark here. For the pulseless ventricular tachycardia, this is also not indicated because the heart here is not pumping blood effectively or at all, not at all. So this is going to make immediate resuscitative efforts like CPR and defibrillation as priority. And so embolic stroke is not a concern in this setting because the circulation is already compromised, and stroke monitoring is not relevant during active cardiac arrest management. And the same thing with the ventricular fibrillation. The priority in VFib is initiating the immediate life support, including defib and effective CPR. So I'm also going to mark an X here. All right, let's move on to prepare patient for unsynchronized defibrillation. What do you think about this one? This is going to be correct for pulseless VTAC, because in this situation, there's no time to synchronize a shock with cardiac cycle because the patient is in cardiac arrest. And unsynchronized defibrillation is needed to stop the abnormal electrical activity, and this will give the heart a chance to restart with a normal rhythm. So this is a priority life-saving intervention. The same thing with VFib. The unsynchronized defibrillation is also effective here because we know that with VFib, the ventricles are only quivering. There's no coordinated contractions. So this is going to result into zero cardiac output. And so here, the goal is to deliver enough energy to reset the electrical system of the heart. So this is going to give the heart an opportunity to resume a normal rhythm. So immediate defibrillation is critical here, along with the CPR. So this is not indicated for the rest of the arrhythmias. Now, document the patient's rhythm and interventions. Of course, this is going to be applicable on all 5 arrhythmias. Yes, all 4. We have to make sure that there's accurate documentation on each of these to help track the changes in the rhythm and guide pacing decisions for the third-degree heart block. And for AFib, when you record the rate, rhythm, and response to medications or cardioversion, also supports treatment decisions. And the same thing with the rest of the arrhythmias. Lastly, we have provide patient education on long-term anticoagulant therapy. Do you think that this is applicable to all? Well, no. This is only indicated for atrial fibrillation with RVR because of the risk of thromboembolism, especially that there is stagnation of blood in the atria. And you're going to make sure that the education about the bleeding risk while they're using the anticoagulant, the compliance to using the drug, and also monitoring for the INR or the prothrombin time when they're using warfarin is very critical here. So this is only applicable to the AFib with RVR, and it's not going to be appropriate for the rest of them. And so the strategy that you should be using in this case scenario is to, first, you gotta identify the type of rhythm. So begin by identifying the specific arrhythmia that you're dealing with. So you have to, let me change my pointer here. So you have to ask yourself if the heart rate in this patient is fast or is it slow. So whether the patient has a pulse or not, and whether the rhythm appears organized or chaotic. So these characteristics will guide you to selecting the appropriate management and also to determine the urgency of your response. Now, the next step in this test question is to use categorization strategy. So this is going to help you mentally organize the interventions based on the type of arrhythmia that you're treating. And so, for example, with the case of an atropine administration, let me activate my pen. With this one, atropine is used to increase heart rate, indicated for someone who was bradycardia. So it only fits for a person with a third-degree heart block. While diltiazem is something that is indicated for atrial fibrillation with rapid RVR, I should say. And so with amiodarone, which is intended for ventricular tachycardia and defibrillation for pulseless rhythms like VFib. And you get a group options like this to help you sort out the correct choices in this matrix type of question. And you also need to use pulse first to help guide the emergency management, especially in life-threatening arrhythmia such as the VTAC or the VFib, which always you got to always determine if the patient has a pulse. So in a case if a pulse is present, the treatment might include the administration of those IV drugs, or it could be synchronized cardioversion. However, if there is no pulse, such as pulseless VTAC or VFib, the correct interventions, I should say, are CPR and unsynchronized defibrillation. So you never delay life-saving interventions by choosing options like medications, like amiodarone or cardioversion for pulseless patients. So you got to keep that in mind. And you also need to match the treatments specifically to the rhythm. So some treatments are highly specific to certain arrhythmias. So again, for atropine, this is only used for symptomatic bradycardia in a case of third-degree heart block. And the diltiazem is used to slow down the heart rate in AFib with RVR. And the transcutaneous pacing is indicated for the third-degree heart block, not for AFib, not for VTAC, not for VFib. So you got to avoid selecting treatments that do not align with the pathophysiology of the arrhythmia. Also, you have to know the differences between the cardioversion and defibrillation. Because with synchronized cardioversion, this is something that you anticipate for a patient who has organized rhythm with a pulse, such as AFib or VTAC with a pulse, especially when the patient is unstable. But in contrast, defibrillation is something that you expect for a patient that has pulseless VTAC and VFib. So you got to know when to use each intervention, which is a high yield concept that comes out in the NCLEX. And don't forget about recognizing the signs of hemodynamic instability. So don't neglect identifying if the symptoms are hypotension, if there's chest pain or altered mental status, or maybe syncope, or maybe shortness of breath, which are all indicating hemodynamic instability. And so when a rhythm causes these symptoms, the intervention should be done urgently for this patient. It could be cardioversion or possibly pacing. And avoid those antiarrhythmic medications, incomplete heart blocks, right? So amiodarone, diltiazem are contraindicated for a patient with a third-degree heart block because this will worsen the conduction problem. So what they need instead is atropine or transcutaneous pacing, or it could be permanent pacemaker. And lastly, I want you to use the process of elimination based on the rhythm and treatment mismatch. So for example, it would be inappropriate to use pacing for VFib or give atropine for an AFib with RVR, because these interventions would either be ineffective or it can only worsen the condition. So you got to always ask whether the treatment would logically improve or it could worsen the specific rhythm. And so that's it for this exercise. And if you find this review helpful, click the subscribe button and like button. Share with your friends who are preparing for the NCLEX, and keep up the momentum. You got to believe in yourself. And I hope that you're going to crush that NCLEX. And also, I wish you all the success as you take this final step. I'll see you again in the next session. Thanks for watching.